So thank you very much, Chris. I'm excited to introduce a colleague of mine, Rita Colwell from the University of Maryland, known to many of you for her groundbreaking work on contamination and effect of climate change on aquatic pathogens. So Rita, please.
Thank you very much for the opportunity to speak with you this morning. I'm really going to extend what Jim has presented so nicely, the merging and interaction of the biological and the medical sciences and the disciplines within the sciences, but I'm going to extend it directly to the environment. And what I'd like to explain this morning is how closely we are intertwined and linked very directly to the oceans, the plant and animal life around us. Water-related diseases is essentially the ultimate focus of the talk, and clearly you can see that there are at least 24 diseases that are transmitted by water. By simply providing safe water, we deal with these 24 diseases, and the numbers of people affected by them are rather astronomical. Just cholera and diarrheal diseases alone, it's 1.5 billion cases every year and close to 2 million deaths. So it is not insignificant. And then when you add the waterborne vector of malaria and the other water transmitted diseases of schistosomiasis and amoebiasis, the numbers are really very, very compelling. I'm going to summarize a lot of work in a very short time. Right now, I'm just showing you a slide that indicates that the bacterium Vibrio cholerae, the causative agent of cholera, is naturally occurring in the environment. This was when we first proposed this 25 years ago. It was not, I shall say, not received very pleasantly by the epidemiologists who felt that it was only transmitted person to person. But we were able to show clearly that the bacterium is really the natural flora of the copepod and is associated by virtue of being food for shellfish and crustaceans. It is part of the flora of the environment. In fact, Vibrios in the natural aquatic environment are essentially the E. coli of the animals in the marine and aquatic world. Certainly, under conditions of poor sanitation, there's very definitely person-to-person transmission, but it's clearly important to understand that it's the environment from whence the organisms derive. And one would say, well, why can't we just eliminate them? The reason we can't is because these bacteria fix nitrogen, cycle carbon, and the Vibrio cholerae themselves, about 20% of them are bioluminescent, and all of them have the ability to break down chitin, which is the exoskeleton of the crustaceans, and certainly of the copepod, which is the dominant microscopic animal of the world oceans and aquatic systems, rivers, and so forth. What are the relationships between the climate and cholera? Well, over the last 10 or 15 years, it's become pretty obvious that rainfall, flooding, how high the river, the Gangetic Delta rivers of the Brahmaputra and the Ganges, when they're low, there's a good mixing of sediment, which carries a lot of microorganisms, transmitted bacteria. And when there's flooding, of course, it brings sewage into the water system. We were able to show a close relationship to the copepod, and in figuring out this annual cycle, we found that the phytoplankton, which become dominant in the spring, are the food for the zooplankton or the copepod. And this could be related quite nicely in Bangladesh, where epidemics of cholera occur year after year. We could relate sea surface temperature to the fact that in the spring and fall, there are major outbreaks of cholera, endemic cholera, spring and fall, year after year. By measuring chlorophyll by satellite and correcting for the time lag between the phytoplankton bloom, which you can measure because you can measure chlorophyll and sea surface temperature, and calculating the time to when the copepod bloom, the zooplankton bloom, would occur because it feeds on the phytoplankton, we found this rather amazing direct correlation of the sea surface temperature in blue and the numbers of cholera cases in Matlab, Bangladesh, right near the Bay of Bengal. So this demonstrated that there is this planetary relationship of human disease because of the interconnectedness of the carrier of the bacterium, the ingestion by humans, and the fact that the bacterium affects the human. I would say, to just put it in a colloquial phrase, as if we were one great big copepod and it's trying to help us osmoregulate, but instead we end up with severe diarrhea and fierce vomiting, and if the fluid is not replaced, then of course death follows. We've become very sophisticated in our modeling, with much more advanced in the last couple of years, studies in Calcutta and MATLAB. We've been able to demonstrate a quite clear relationship in our model between the predicted from the model and the actual cholera cases for Calcutta and Bangladesh, to the point where when there's an increase of about a milligram per cubic meter in chlorophyll measured by satellite, there will be a 33% increase in the number of cholera cases in Bangladesh. And if there's a millimeter per day increase in rainfall, a 7% increase in cholera, both in Calcutta, but also in Bangladesh. So there's a direct relationship between the environment and this waterborne disease in those countries. Now, doing some historical work, we went back because it was discovered that by my colleague, Elizabeth Whitcomb, Dr. Whitcomb, who did a PhD studying the hydrography of India, and then she's a New Zealander, a Kiwi, went back to New Zealand to get a medical degree, practiced medicine in London, but discovered that in the libraries, in the History Museum, they have the historical records going back to 1823, 1840 to about 1947 for all of the cholera and malaria deaths in India. So putting all of these data onto the computer, we focused really in this area around New Delhi. We know that there's a year after year, spring and fall, all along the coast of the Bay of Bengal, there are epidemics, spring and fall. But inland, there will be years where little or no cholera, and then all of a sudden, an explosive epidemic. So without going into great detail, we now know that, in effect, there's endemic cholera and epidemic cholera. Let me just give you some of the information because it is very useful in understanding the current outbreaks, such as the one that occurred in Haiti. So by focusing really on the data for these localities for which the data are available on the maps in London, we determined that there's a direct relationship between that sudden massive epidemic and the previous 2 months of very, very hot temperatures, and then suddenly a heavy, heavy monsoon rainfall. So, and then coupled with a religious festival or a large gathering of people or a disaster such as an earthquake. And so this model, which we were able to develop from all of these data that we gathered from the historical records for India, we now know that when there is an above average air temperature for the 2 previous months, and then suddenly a very heavy rainfall, and then you have a system where there's either a poor or a damaged infrastructure for delivering water and handling sanitation, the risk is very, very high. So could we have predicted the Haitian cholera outbreak? It's very obvious that cholera is a serious threat today. In fact, in Africa, cholera is probably the most serious of the epidemic and transmitted diseases in that country. So with this framework, we were able to determine the difference between epidemic cholera and the occurring in non-endemic regions and the and seasonal cholera. So what occurred in Haiti was quite fascinating because there were cases in Port-au-Prince, but it was considered that the location of the original contamination, that is where the Nepal troops were located, was at the origin of or near the origin of the Ashanti River that flows down into the coast of Haiti. But in fact, cases were occurring almost simultaneously in that period of time in 2010 in the fall. Now, just to give you some background, you will remember in the year 2010 in January, there was the very severe earthquake. It was a Richter scale 7.5, devastating. But what has been learned from the work that we've done, both in gathering from different parts of Haiti within the 2 weeks that in October to November, mid-October to the beginning of November, from about 80 patients, we were able to get stool samples. But going back to all of the historic data, as far back as we could go, downloaded from computer records, the air temperatures in Haiti in 2010. And what happened that year was that there was the hottest summer in 60 years. And you can see June, July, August, the red line is 2010, and the air temperature on average. So it was the hottest in 60 years. Similarly, the rainfall was the heaviest in 60 years, June, July, August, September. What happened was that a hurricane skirted the island as if they hadn't had enough trouble with the earthquake in January and then that severely hot summer, and then the hurricane that skirted the island in late September dumped the heaviest rainfall in 60 years on that country. So that fit the pattern for epidemic cholera as we observed occurring inland in India. The stool samples that we were able to gather from the 80 patients with Dr. Prosper, the Haitian physician who collaborated with us, a terrific individual, we sequenced the bacteria that we isolated from the stool samples, and we found that indeed there was quite a cluster of the Haitian strains. And doing a principal component analysis, we found that in fact the Haitian cluster cloud had one sequence that was associated with it, but that happened to be from Zambia. So I think it's very important to conclude that there may have been an introduced strain from the Nepal troops, though the troops that were tested, none were positive for cholera in their stool sample. In any case, the point I would like to make is that here we have an example of the interaction of the environment, the weather patterns, and this devastating disease that hit at a time when the population was most vulnerable. The genetic analyses were fascinating in that they were quite specific characteristics of mutations in some of the genes that were in the Haitian isolates, some deletions and some duplications and so forth. Now, let me just close because this is an education and culture interaction. We're demonstrating how holistic we must be in understanding and dealing with public health. It occurred to us that we had spent the last 25 or 30 years, working in Bangladesh, we now know that the copepods are transmitting the disease as a carrier. I would call it a vector. It's waterborne instead of flying, is a mosquito. In my view, it's a vector. We have used satellite imagery to be able to predict times of the outbreak. What could we do for the villagers themselves who are remote from the major cities and suffering cholera? How could we help them prevent it? So doing some laboratory experiments with a variety of very simple filtering materials and being able to show we could remove 90% of the copepods and particulate matter, we wanted to determine whether this would be a simple way to reduce cholera in the villages. And so with an assistance of the National Institutes of Health, we did a 3-year study in 50 villages with 150,000 people. And the way we did this was to essentially develop healthcare extension agents, much like the agricultural extension agents. And these women were taught how to take a square of used old sari cloth, fold it 4 to 8 times, and then place it over the calash where they collect water for their family for the day, and pour the water through the filter. It was pretty obvious, didn't take a whole lot of convincing for our extension agents and for the women in the villages to see that the water that was clear after filtration compared to the turbid water that they were otherwise serving to their families for their drinking water source, and explaining that the little critters that were swimming around weren't terribly good for their children. It didn't take very long, a matter of minutes, for them to understand, and we were able to reduce cholera by 50% in this population. Then we were asked whether this was sustainable. So 5 years later, the Thrasher Foundation awarded us a small grant to go back and determine the effectiveness for those we had taught to filter and the control villages to compare the cholera rates. It was very difficult because the control villagers had discovered the filtration, so everybody was filtering, or at least 75% of the population. But what we did learn was that if you were lazy and didn't filter, the herd effect, as you have observed with vaccines, worked here. So though you didn't filter, if you were surrounded by families who filtered, you were protected. So this is, I think, an example of condensing all of the sophistication to understand the transmission of this disease, the relationship to the environment, and to be able to provide a simple, workable technique for the population. I close with the words of John Muir, the founder of the Sierra Club, who said, when you target one little thing in the universe, in nature or the universe, you find it hitched to everything else. I would say he and she finds it hitched to everything else. I'd like to acknowledge 4 of the many, many, many colleagues who've been enormously helpful. Dr. Huck, a student who did his PhD with me, that went back to Bangladesh to run the clinical labs there, and then I enticed him back to the University of Maryland to run the labs there, and he is now a professor at the University of Maryland. Dr. Jutla, who is now an assistant professor at the University of West Virginia, former postdoc, and we continue to collaborate on all of these model building. And then Dr. Hassan and Dr. Sion Young, who are incredibly helpful with the genomics and the genomic work. But ultimately, we all work together to find ways to provide safe water, particularly on a planet that is destined to be affected severely by climate change in the years ahead. So with that, I thank you very much.